Welcome back, guys. Thank you so much for downloading this episode of the True Sports Physical Therapy Podcast. Today's guest is Dr. Susie Spirlock. You guys all probably know her as Dr. Susie Squats. You can find her on Instagram at Susie Squats. She graduated from Western Carolina University with her doctorate in physical therapy, and she made a massive career switch and 180, which we get into in this episode, where she was working what she describes as a soul-sucking job. So for those of you who are working in that soul-sucking job, this is your antidote to that. She talks about how she got out of that and really unlocked her potential with her Susie Squats platform. So go and find her on Susie Squats. She has some awesome offerings, including an upcoming online Hypermobility course. That is the niche in which we spend a lot of time talking about. How do you rehab the hypermobile athlete? Different tips, different tricks as to how to cue those athletes, how to progress those athletes. She has an awesome email list as well, where she gives out absolute gold in terms of how to handle your caseload and also how to overcome your own pathologies. So check out her email list. You can find that on her link tree on her Instagram, Dr. Susie Squats. This was a wide-reaching conversation. I hope you guys get as much out of it as I did. Let us know how we did. You can find us, True Sports PT, on Instagram. Always open to feedback. Susie actually came to the program from a recommendation from one of our past guests, as well as a number of listeners. So without further ado, here is Dr. Susie Squats. And welcome back to the True Sports Physical Therapy Podcast. We got Dr. Susie Squats, Susie Spirlock. Welcome to the show. Thanks so much for taking a couple minutes out of your day.
Yeah, absolutely. For those of you who are listening and don't know who I am known as Dr. Susie Squats on socials, and my husband and I always joke and say we're going to actually change our last name to Squats because, I mean, his name is Steve and I'm Susie and our last name's Spirlock, so all the S's just kind of run together anyways, and it'd be so on brand.
Makes a lot of sense. That makes a lot of sense. My wife's name is Kiss, Kiss. So I always say I'm going to take her. I should have taken her name, but she went with Rosenblatt. Go figure. We all make ridiculous decisions. So I've made a lot of ridiculous decisions when I deal with a hypermobile athlete. That's a bit of a niche for Susie Spirlock, for Susie Squats. Tell me about the way you think about Ehlers-Danlos, what the hell it is, and how you begin to think about that population.
Yeah, so I actually have hypermobile EDS myself. I was diagnosed later on in life. I believe I was 26 or 27, and I'm now 31. And this is some sort of a trend that we're seeing a lot with this population is people, especially like younger athletes, kind of go throughout their time playing sports, and they'll have various injuries like ankle sprains, a lot of like tendonitis related things that I usually see, and I personally went through myself. And then as they kind of get older, we start to see other body systems sort of start to show up. And that's when a lot of these people are starting to seek out these diagnoses of EDS, the hypermobility specific spectrum, or the hypermobile spectrum disorder, because they just want more validation and like why their symptoms are showing up as they are. So it is a very, very wide spectrum, which makes things very difficult to treat and train as coaches and clinicians, because you can have someone with EDS like myself who has a lot of different body systems involved, but you could consider me technically pretty active. I lift weights, I can go on some runs, I can go about my daily life activities without having too much of an issue. And then you have other people on the side of the spectrum who can barely get out of bed and have diffuse joint pain and have really, really bad like autonomic nervous system dysregulation symptoms. And so it can be really difficult to try and narrow something down when we compare it to, let's just say, like FII, hip impingement stuff in like the normal population.
Yeah. Funny you mentioned that diagnosis, because I feel like that shows up a bunch. I had a conversation. I encourage everyone listening to kind of go back and listen to my conversation with Dr. Andrew Wolf. So Andy Wolf is a hip specialist in the DC area. He's an all cash guy. He's the cream of the crop as it pertains to hip and hip scopes. And he's come a long way on it. And I used to see his patients, and some patients would do really well, some patients not as well. And what we started to learn is that the hypermobile hip joint doesn't do as well with these FAI corrections, and we're trying to figure out why. So you kind of highlighting that makes a lot of sense. What do we do with the hypermobile hip?
Oh my goodness. So I myself, funny enough, went through a nice bad bout of symptomatic FAI and found out I had a labral tear back in 2021. And what we know from the research and the evidence is that a lot of these labral tears or like bony changes from the hip joint, especially in hypermobile people, are actually occurring during their puberty years when they are playing rotational sports. And usually they're not showing up until like later in life when we have a sudden onset of change of activity or forces to the hip joint. For my personal case, it was changing my squat stance and not adjusting the amount of load that I was lifting after that squat stance change. And when we are dealing with painful, pinchy hips that may or may not have a labral involvement in clients with hypermobility, it can be a hard road out of that. It took myself an entire year to get out of that and get back to squatting normally. I know a lot of clients my team and I work with, it can take, anywhere up to like 6 months to a year to kind of get back. And part of that is because obviously our connective tissues are pretty lax, and our ligaments are also extremely lax. And so we really rely on the muscles, the tendons in order to basically kind of hold our little bodies together. And when we see hip pain, especially anterior hip pain, we usually have a contribution of hip flexors, adductors, and abductors that are also affected within the hip pain itself. And so you really kind of have to attack it from all different directions with a lot of hip stability, a lot of calming the tissues down, calming the nervous system down, and then finding that entry point and then just slowly rebuilding very, very slow over time.
Okay, so when you have an inflamed joint like that, let's say, because you talked about calming it down, how do you tackle strength stability while trying to calm down a joint?
So I always like to take the approach of using isometrics to our advantage. We know that isometrics, and really anyone, not even just hypermobile clients, can have a great effect on decreasing pain levels and also an increased effect of increasing strength. So isometrics can be a really, really great entry point, especially for the hypermobile crew, because not only are we working on some of the hip stability components, but we're also working on decreasing some of that just baseline pain by talking to our nervous system a little bit more and letting it know it's safe. And then while working on those isometrics, we, as in my team and I, love to find an entry point to a squat pattern, just because squat is normally the most symptomatic of the movements whenever someone's dealing with symptomatic hip impingement, to where they can do it on day one. And for some people, that may look like their typical normal back squat, but with just a little bit of the bottom range of motion shaven off. And for other people, like myself, when I went through this, I had to go from my back squats of 185 pounds all the way down to holding 2 5-pound dumbbells at my shoulders and squatting to a super high box with a very, very shortened range of motion.
Okay, so limiting range of motion, introducing some isometrics can help calm that down. Anything else like modalities that would help in calming it down?
When it comes to modalities, obviously use those in a way that you see fit. But at the end of the day, we kind of have to think about modalities as a way to open up a window so that we have decreased pain levels. And then we're getting on our feet, or we're getting into some sort of position where we're actually giving active input into that system. So modalities, I mean, I know some people feel really good with dry needling. I know some feel better with heat packs, but in the virtual space that I've been in for the past 2 years, I've found much more success with a more active approach. But then again, we're not like totally just, crapping on our modalities, but we are going to be using those as a way to kind of help along versus just only focus on those.
Okay, so that sounds like one common mistake maybe that therapists can fall into is relying too much on modalities, not necessarily using it to like push the ball down the field. What other mistakes would you say is common from a sports PT when treating the hypermobile athlete?
Definitely focusing too much on static stretching.
Okay, yeah, stop stretching because you guys are super mobile. Okay, so oftentimes, now, is there any place in which we can be stretching safely? Let's take that hip example.
I wouldn't necessarily say, stretching isn't unsafe for those with hypermobility, but it's not going to get you the same results as something like an active approach, where the client's actually controlling that range of motion and controlling the muscles surrounding the joint. Because when we look at a hypermobile client, our ligaments are super lax. Our muscles often feel tight because our nervous system is already in overdrive, sending a ton of signals down to certain muscle groups, especially upper traps, posterior pelvic floor, hip flexors, and calves a lot. It's what I kind of see clinically. And if we just only focus on stretching those certain joints or areas, then the nervous system, yes, we're still talking to it a little bit with the stretching, but we're not getting much carryover into helping our nervous system feel safer. We're just saying, hey, this thing feels tight. I'm going to go ahead and stretch it out a ton. But right after that, our nervous system is doing a little bit of freak out because now it had an end range of motion stretch to a joint or an area that already has extra mobility and extra range. So now it's probably most likely going to tighten up a little bit more.
Okay, so walk me through, like rubber meets the road. How do you coach that when they come in with the tight upper traps? Like, what is that in between?
So if we're talking about tight upper traps with a client with hypermobility, instead of going through stretching, I am working on breathing drills, trying to get like 360-degree expansion around the rib cage to try and get diaphragm to, be in synchronization with pelvic floor and with all the accessory muscles up in the upper neck. I'm also loading their upper traps. I'm giving them a kettlebell or a dumbbell. I'm having them hold it in one hand. And on that same side, as they shrug up with the dumbbell, they're going to tilt their head towards that side for that nice contraction in that shortened position. And then as they go down, they're going to tilt their head away. And so, yes, we're still getting a little bit of a stretch at that bottom position, but we are doing it in a way where we are keeping constant tension on the muscle that we're actually trying to work, which helps the nervous system feel safe in these extra bendy humans.
Okay, love extra bendy humans. I like that. And by the way, like it is important to just a quick call out to what you were saying about this spectrum. I had a patient early on in my career who had it was the first time I ever saw the words Ehlers-Danlos. I didn't really know what that meant. And she would raise her hand in class and dislocate her elbow. So like that's like one side of the spectrum versus I have a little bit of laxity. I'm a little bit hypermobile. So it's really a wide range. So the example you gave with the upper trap, trace that now to the hip because we see so much of that. Give me a concrete example of how you treat that hypermobile hip with some of the techniques you just described.
Yeah, so prime example is hip flexors feeling super tight in these bendy humans, myself included. So not only are we not stretching them from a point of, hey, we already have a hypermobile area, but a lot of times also looking at neural tension too. So I'm also looking at neural tension in regards to the upper traps. If we're holding any upper limb tension there, giving some nerve glides. And same thing down if we're looking at the hip. Instead of stretching the hip flexors with a couch stretch or a Thomas stretch, what we're doing instead is we're loading them. So option for that could be getting someone lying on their back with feet up on a bench or a table with a mini band around their feet and doing some hip flexor marches. Another one could just be quite literally lying on the ground with a band tied and anchored to a point a little bit further away. Other portion of the band held on the top of the foot and then pulling up into hip flexion and then slowly controlling your way back down. And then I'm also coupling that with some femoral nerve glides. My favorite way is to do those in half kneeling with hands on the knee and then moving the head as the pre-tensioner and tension reliever at the top portion, and then kind of shifting further into hip extension with the hip from that point. So kind of coupling the two things together, focusing on some creation of tension through controlled, slower tempo strengthening of the area, and also addressing any increased neural tension because most of these hypermobile people are going to have increased neural tension.
Yeah, that's super interesting. Okay, so you're loading it and you're paying attention to the nervous system with some of those nerve glides. You'll put those together in like somewhat of a superset. I love that. Talk to me about how you roll that out in your offering. So you have hundreds of hypermobile athletes that are reaching out to Susie Squats. How do you treat that population individually when these symptoms or presentations can be so disparate?
So it can be hard, and that's kind of why my team and I really kind of thrive on doing, one-on-one rehab coaching. For that reason, is because everyone's going to present a little bit differently. But just generally speaking, like when I do education and posts about hypermobility, I will just give, the example of a supine hip cable flexion march and then a half kneeling femoral nerve glide, and then obviously talk in the caption or give more education of, for your nerve glides, some of you are going to be able to go a lot further into that hip extension, and some of you are going to only be able to go a little bit. But the main thing we want to do is stop when we start to feel any of that super increased tension, because we don't want to push past the capacity of a nerve and risk making it super angry.
Yeah.
And then for hip flexion exercises, I mean, sometimes just a good old basic standing, arm supported mini band around the feet, marching up and down is pretty much what someone can only tolerate and handle. And then if you have someone who has autonomic nervous system issues like POTS and orthostatic hypotension whenever they stand up, then we might want to try a lying down variation first. So it really kind of depends on the person in front of you and what other body systems they have involved, and just finding where their entry point is.
Yeah. Okay. That makes a lot of sense. And now understanding that you do that in a more one-on-one fashion so you can be more specific, that also clarifies that. Tell me about the POTS world. Why is this an issue with Ehlers-Danlos? What's physiologically, what's going on there?
So with POTS, so POTS stands for postural orthostatic tachycardia syndrome. Basically, when we have changes in position, from lying down to sitting, from sitting to standing, we are seeing a massive increase in the heart rate, which makes us dizzy, which can mess with our vision. And it can also really make cardiovascular exercise extremely difficult. It can lead to chronic fatigue, brain fog, basically just affecting the whole entire nervous system. And it used to be thought that things like EDS and POTS were pretty rare, but now we're seeing this become a lot more common and a lot more mainstream, and it's really not as rare as we think. I think the numbers used to be like 1 in 5,000 for EDS, and now we're looking more at like 1 in 500.
Wow.
So I think a lot of that is due to the fact of the increased incidence and a lot of these symptoms and like sub-diagnoses that became more apparent after a lot of people got COVID back in 2020. I'm a walking example of that. A lot of my symptoms with EDS got way worse after having COVID, just because COVID was basically an insult on my immune system, which is one of the factors that can be affected with EDS and be a little bit more, what's the word I'm looking for? Just vulnerable, I guess. And so we're seeing a lot of this come out of the woodwork in the past 5 years, and a lot more people are getting diagnosed, just because diagnoses can help sort of validate that experience. So talking about POTS, POTS can be improved. It is not something that you have to live with for forever. I know a lot of people, their POTS symptoms really spark after a pretty big insult to the body, whether it's a viral infection, bacterial infection. I know a lot of women experience it who have EDS after getting off of birth control, if they've been on it for like 10 plus years. So it's basically sort of just a very stressful insult to the body itself. And that is what can send the nervous system a little bit more for a loop. And we start to see some of these POTS symptoms sort of make their way into our lives.
And so how do you treat those?
So that is a very good question.
Nice.
And it is a combination of having a really good healthcare team behind you, having a good cardiologist, maybe even a neurologist. We can improve POTS with things like exercise, finding a starting point for exercise, even if that means the initial entry point for you is lying down and doing a chest press with 5-pound dumbbells. So exercise both with strengthening and cardio is important, because the strengthening is going to help with blood flow and building our muscles up and reduce the amount of blood pooling that we're kind of having in our legs and extremities, to increase some of that blood flow back to the heart and to the brain, which is where we see a lot of these symptoms happen. And then increasing slowly over time the cardiovascular aspect of it also helps with making sure that we're getting enough blood and oxygen to the lungs and also to the brain. But it takes time when we're dealing with POTS. It takes a lot of time. And then we also need to make sure we're looking at the other body systems, because POTS is very sort of sensitive, and people with EDS can, and just hypermobility in general, can have other factors at play, like gut infections, whether it's SIBO, whether it's Candida, as well as something called MCAS, which is mast cell activation syndrome, where your mast cells, your immune cells are just overactive. And we can also have histamine intolerance, where our bodies can't really get rid of histamine or are producing too much histamine, which then causes POTS to be even worse.
Jesus Christ. Okay. So
I know.
So how, when it gets to that level, and there's so many different things that can tick this thing up, what is it, a constant series of watching what triggers it and then adapting to it? Is that what you have to do for the rest of your life?
Yeah, so it is a constant just deep dive into your life and finding what your triggers are. A lot of people for POTS too, like hot, humid environments can be a factor. So like hot showers can be triggers for people. Working out in hot environments can be triggers. And so it's really education as the foundation of all of this stuff, because a lot of people, when they have these symptoms, they haven't known to sort of track and see what makes them worse or better. And so education and finding trends to what you react to the most is super, super important. And then working with providers who are educated in this stuff, because it can be easy to kind of just look at hypermobility as, oh, you have got a connective tissue disorder and your ligaments are extra lax. Let's look at the joints, let's look at the muscles. But we forget that there's so many other body systems involved, from cardiac to respiratory to the GI system to immune system, and even down into like pelvic floor. We see increased incidence of PCOS and endometriosis. So it really is a full body approach that you have to take into consideration when working with hypermobile clients.
I mean, that education piece is so important. I think as providers, if we don't know that, we don't really know what to look for. It's also, you bring up the incidence levels and the rates of occurrence. If we're at 1 in 500, some of these athletes are insanely high level. They just didn't know that this was transpiring. And sometimes this pathology, for lack of a better term, can be a benefit to their given sport, right? So like, I think I go immediately to the high level pitcher. Like, they have to reach these crazy ranges of motion to develop force and torque to throw a pitch 100 miles an hour. It could be that part of that is an underlying system of hypermobility. And so it's like dancing in between. We don't want to rob them of that necessarily, but to understand some of the factors that go into it, I think that goes a really long way. Have you seen high-level athletes dealing with this hypermobility?
Oh, yeah. Katie Ledecky, the Olympic U.S. swimmer, I'm not sure if she has hypermobility, but I know she has POTS. And she literally competes at the Olympic level with POTS. And I mean, I played soccer in college with hypermobility and EDS, not even knowing that I had this stuff. And so just because, I want to make it clear that just because you have these diagnoses or a connective tissue disorder doesn't mean that you have to be bedridden, and doesn't mean that you shouldn't be doing things and trying things and pushing your body and trying to be active and lifting heavy weights and running long distances and, you know, throwing and pitching balls. It just means that we may need to have a little bit of a different approach when it comes to this, and making sure that we're giving our body more time to adapt, just because we know that tissue healing time is a lot slower when you have connective tissue disorders. But this doesn't mean that you have a big like red stamp on your forehead that says, do not lift weights, do not run, do not do anything, live in a bubble.
Yeah, I think that makes a lot of sense. So as we were saying, with the hypermobile athletes, so you talked about isometrics, you talked about the import of needing to load and control that load. Then when we get to producing and receiving force, my head goes towards plyometrics. How do you get a hypermobile athlete that's dealing with POTS, that's dealing with EDS, through some type of plyometric training?
So we need plyometric training more. Okay. So, I mean, we need strength, we need plyos, we need those things more than we need stretching and rest, because those are the things that are going to help sort of build resilience in our body, build resilience in our joints, so that we can do the hard things. And so, I mean, we're approaching plyometrics the same as we would strength work. We are finding an entry point. So if we're thinking about lower body with someone who has recurrent ankle sprains because of hypermobility, and they want to get back to the field and reduce the incidence of these things happening again, then we are finding a way for them to do plyos as soon as we can. And that may look like double legs, band supported plyos, where a lot of that force and slack and force absorption is being taken up by the band itself. And then we can progress to things like single leg, and then no band, and then single leg like broad jumps, and then get back into some of our cutting movements and exercises. So, I mean, I feel like the same principles apply sort of across the board when it comes to strength, cardiovascular exercise, and plyometric training and power training. Entry point first with these clients, and then use the wonderful, beautiful RPE, RIR in order to make sure that we're hitting the proper intensities for these folks to where we can see tissue adaptations take place, but not so much that we're pushing way far past their current capacity, which can then result in increased injury risk.
Okay, so it's really about that starting point, like finding a proper starting point, and then all the same principles apply in terms of how you progress, how you scale. Anything of note in the hypermobile athlete, the EDS population with hypertrophy? Is there any way in which they respond to stimuli differently?
I don't really think so. I haven't seen any research on it, and I haven't really tried to pay attention to myself. I haven't had any issues gaining muscle mass over the course of my life, as long as, eating enough calories, taking your sets close enough to failure, and then making sure that you're hitting each muscle group 2 times per week with the 4 to 6 sets. So that's a great question. I don't think there's too much of a difference, just because EDS is affecting more of the connective tissues themselves when it comes to the ligaments, the joint capsules, linings of the organs versus the muscles themselves. But I mean, that would be a super interesting study and topic to kind of look into.
Yeah, not like I've seen it. I just wonder if there's anything out there. How about on the nutrition side? You mentioned calorie intake. Tell me what's important. There's got to be something that's important in the POTS EDS population that's important to know as providers when we're counseling on nutrition.
We need more salt.
Okay, why?
So especially if someone is having POTS-related symptoms like the lightheadedness, the dizziness with changing position, we need more salt to try and help with our just overall blood levels. So hydration and salt or electrolytes, extremely, extremely important for us. We can help reduce a lot of those POTS-related symptoms when we are hydrated enough and when we have enough electrolytes in our systems. So I myself, I think I usually anywhere from 3,000 to 5,000 milligrams of sodium per day, which is, way past the daily recommended for a typical individual. But I have also had clients who have been recommended by their physicians to go all the way up to 10,000. So again, another one of those person dependent on what makes you feel good. But I feel like as a society, which especially as Americans, we've been told to, low sodium, cut back on the salt, which for the majority of the population, if you have cardiac issues, family history of cardiac issues, we definitely want to pull back on the salt because we love to dump salt on our food literally anywhere we go. Yep. But for people with hypermobility or POTS, we definitely want them to have that salt.
Okay, super interesting. Anything on the protein, carbohydrate side of things?
So protein, just pretty much like anyone else, we need to have a good amount of protein. I normally have people shoot for anywhere from 0.7 to 1.0 per pound of body weight. A lot of people around that 0.7, 0.8, that's going to be kind of the sweet spot, just because we know for anyone, we do need protein for muscle and tissue repair and have it as those building blocks. And so it's no different for people with hypermobility. We, in my opinion, arguably even more important to have the protein in there so that we can rebuild some of these tissues in a way and just help that overall healing process. Yeah. And then when we look at carbohydrates, I haven't really seen too much difference when it comes to carbohydrate intake for the hypermobile population, but something that is important if someone is experiencing GI symptoms. So let's say, they complain of nausea before they go and start a game or practice. I'm asking the question of, okay, when's the last time you ate and how much did you eat? Because a lot of times in the hypermobility community, we may have delayed gastric emptying within our stomachs, or we may have just slower motility through the small intestine and into the large intestine. And so a lot of times smaller, more frequent meals can be more beneficial, not only from a digestion standpoint, but also just kind of keeping blood sugar levels a little bit more flatline, streamlined throughout the day as we go into some of our exercise with practice and games.
Okay, that's awesome to highlight. I'm glad I asked that. I just had a strength coach, nutrition coach on, and he really highlighted some of our deficiencies as a profession as it pertains to nutrition. So when dealing with this specialized population, how important that is. I appreciate you highlighting that. Tell me a little bit about how you got to where you are, because I think you've taken an interesting path to being all virtual. You said, I think off air, that you have not treated a patient in person for 2 years. Tell me about like how you got to that.
Yeah, so it's actually, kind of a funny story. I graduated from PT school in 2020, the wonderful year of COVID.
Yeah.
And my husband is active duty Air Force. And so we got married, like I graduated PT school. We got married January 4th of 2020. And then 2 days later, we moved to a very, very rural Altus, Oklahoma, middle of nowhere, like the little like turbine things like going across the road, sort of rural. And my only really option was to work at a hospital-based outpatient clinic. And so as a new grad, I was like, okay, we're going to be here for, 3-4 years, maybe. Just going to suck it up. I'm going to do it. Because in all honesty, in PT school, I wanted to be working in inpatient rehab on like a neuro stroke TBI floor. So
that's crazy.
Took a big 180 in the past 5 years. But so, I'm treating in this clinic. It's your standard, typical PT clinic where we have a ton of treatment tables. For equipment, we have a total gym, we have a like little new step bike, and we have TheraBands. Like there's no weights, there's no really anything like gym equipment wise. So, I made with the best of what I had. I was the one that, all of the high school athletes got sent to. Anyone with hypermobility, I treated a lot of, active duty Air Force. And as I'm doing this, I'm literally buying equipment like kettlebells and dumbbells and bringing it into the clinic because these people need more stimulus than just your traditional like cookie cutter PT where you come in, you get a hot pack, you get some e-stim, you get some low level manual, and then you do low level exercises and you're told to go on your way.
Let me cut you off. How did that happen? How did that become the norm? Was that just a dollars and cents game? I don't understand how that ever worked.
I honestly don't know, because even like looking back to when I went to PT for hip, like gluteal tendinopathy back when I was playing in high school soccer, and I went to PT, like that's what the clinic was like.
Yeah.
And I feel like it's a combination of insurance and healthcare not respecting or really knowing all the things that we can do as therapists, as well as older therapists kind of just keep going in and doing what they do and what they've done for the past 10, 15, 20, 30 years and not really having any fire underneath of them to keep up with current evidence. And then I also think it is partly fault of the just general curriculum that physical therapists are taught in school. I mean, looking back to when I was in school, I graduated 2020, so not too far ago.
Yeah.
I mean, we don't really cover strength training. We don't really cover resistance training. We never touched weights or barbells. It was just diagnoses, special tests, red flags, and some maybe lighter level like Therex sort of interventions.
Yeah, I think we have come a long way. I was going to say hopefully we have, but I think we have come a long way. I mean, I went to school way before you, and it was certainly more of that. I've seen the curriculums move in the direction towards more strength and conditioning. I think it's hit or miss. I think it depends on what grad school you are. Like, small tip that I always get asked, what should I look for in a graduate school, or where should I go to graduate school, really? And my answer to that is figure out, if you can, before you walk into graduate school, what type of PT do you want to be? Then look at the school, and the school will say, hey, we do orthopedics, we do sports, but who is the staff that's providing that education? Who are they treating? When's the last time they treated? Like, if you can get a sense of that, I think that's really good advice to the aspiring sports PT. But okay, so you go in, you're getting the cookie cutter stuff, you're working in a clinic that sounds very cookie cutter. Then when do you start to break out? Because you talked about a soul-sucking clinical job.
Yeah.
Tell me I think you just described what that was, but how the hell did you get out of that?
So backtracking a little bit, I did start my social media Instagram account in PT school, like my first year. I was like, hey, I'm going to start this account. I'm going to document PT school. I'm going to post workouts, fitness stuff. And as I started to sort of post more throughout PT school, it gained some traction. And
Was
that
it
wasn't
was it
my
called Susie Squats?
Dr. Susie Squats.
Okay, it was. Okay.
Yeah. So, it wasn't really my intention for it to go anywhere. It was just sort of like a fun outlet for me to do and post. And then once I got out of school and into this soul sucking clinic job, over the years, people had asked me, would you ever do one-on-one coaching? Can you train me? Can you coach me? I'm having this issue with squats or deadlifts or, running, sprinting, whatever. And I always said, oh, no, no, no. And then my husband, finally, one day after I came home from work in the soul sucking clinic, just in tears, in shambles. And he's like, Suze, I've been telling you, you need to do something with the amount of reach that you have on social media. You need to start your own business. You need to start doing fitness coaching, rehab coaching, start a strength training program, and you need to get out of this. He's like, I believe in you. And this is me like kicking you off the ledge in order to put fire under your butt to do it because you are miserable.
Yeah.
And so then I started to do it. I opened up applications. And then as I got more and more online remote clients, I cut my hours down at the clinic. And then eventually within like 6 months, I was able to replace my entire salary from the clinic. And then I said goodbye, and the rest is kind of history. And now I have 3 PTs that work for me and my business, and we work together as a great, amazing team and do everything remote and virtual.
Okay, so who were your inspirations at that point? Was there anyone you were looking at to say, I want to be like that?
Not really, honestly. I mean, because at the time, it was still 2020, 2022, when the idea of, remote services became popular because of COVID.
Yep.
And so there wasn't really any one person that I remember where I'm like, oh, I want to do what they're doing. It was more of like, here's what I want in life, and this is what's going to get me there. And I just bet on myself and put my head down. And, it hasn't been easy. Yeah, from the outside, it looks great. But I mean, being a business owner is hard. It's not for everyone. And you have to be just really, really passionate about what you're doing and kind of give it your all. And some clinicians out there, that might not be your cup of tea. Like if you want to go clock in, clock out for the day in your job, I mean, that's great. Do that, help the people that you can help. But I just wanted a little bit more or just a different path.
Mm-hmm. Okay, so now you have 3 people working for you. Love that. How did you get to that? Like, what was your first hire? And then how do you find the next Susie Squats?
So basically, once I made the full transition to being on my own, I built up my own client roster. And then I also grew my online group strength training program. So I built my roster up to the point where I maxed myself out. Like, we're talking basically burning out of doing something I love versus burning out doing something that I hated. Yep. And I, sat down with my husband and I was like, I love this, but this isn't sustainable. Like I can't keep just doing this. And I had other clinicians reach out and be like, hey, if you're ever looking for someone to hire, I would love to talk because I'm tired of the clinic life. Like I want to do what you're doing. And so my first hire was actually Dr. Emily Eister. She's Kellogg now since she had married. And she was never really full-time for me. She was a little bit part-time and now is kind of, just keeping a small roster. But then my first full-time hire was Dr. Pat Bell, and he lives out in California. And he was my first hire last June. And within like 4 months of bringing him on, we built him up to a full-time roster, and he was able to leave the clinic entirely. And now all he does is remote coaching with me and the rest of the team. And then my second hire was actually a client of ours, Dr. Bailey Pepper. She came to us for some lower back pain when it came to lifting. We worked through that for about 7 months, I think. And then she was just amazing. And so we hired her on. And now we are all just, working together to try and merge rehab and strength training together and give people a little bit more of what they deserve when it comes to the active population.
Okay, so that is awesome and a great story. I love the way you went about it, kind of building that roster of PTs. How are you getting clients?
All through social media, 100% through social media, mainly my Instagram account. So the PTs that work for me, they don't have to go and like seek out their own clients. I literally give them to them on a little silver platter. I'm like, hey, you have a new client. Her name is Aubrey and she's dealing with this. And then they get started. So all the leads are coming from Instagram. And I think that's like the hardest thing for clinicians who are wanting to get into more of the remote space, because I also teach barbell rehab CEU courses for
Nice.
Dr. Michael Mash, just like for funsies.
Yeah.
And one of the questions I get after each course from these clinicians is like, how do I do what you do? Like, where does all your business come from? And I'm like, it comes from social media that I've been posting on for like 8 years. So that's like the hardest piece, in my opinion, is finding a place to get leads from if you want to go the remote route. And I know some clinicians will say, oh, it's like oversaturated now. And I'm like, no, it's not. And you don't have to have 150,000 followers to have a thriving online remote business. I have colleagues within the social media space who have like 4,000 followers and are fully remote, full-time on their own, and they're killing it.
Okay, so that's awesome. We've had Dr. Mash on the program. He's awesome. Yeah, he's really great. So, okay, so then what does the client get? Like, what are they signing up for? What are their options?
Yeah, so if you're coming to us with pain, let's say you are having shoulder pain with some like elbow tendinopathy stuff with your bench press or your throwing, and you want to get back to playing some like adult league softball and lifting without pain. Yep. You come to us, you get in a call with me, we chat about what you have going on, seeing if we're a good fit to work together, because even though you think you may be good to work with us, I want to vet the same and make sure we're setting yourself up for success. And if you decide that we want to work together, then we get you onboarded in the Train Heroic app, which is the app we use for all of our coaching. We have you fill out a new client intake form, which is just addressing all of like the psychosocial factors. What does a typical day look like for you? Nutrition habits, stress levels, all the other things that can be impacting that pain response. And then we do an initial onboarding call, which would be with your main coach. So Dr. Pat, Dr. Bailey, or myself. And we basically kind of gather a lot more details of what's going on. So basically a big subjective interview. And then based on that, we program a movement assessment. And so that's essentially, it looks like a workout that we program in Train Heroic. And it's just exercises that we have you film that we want to see. That can be something, if we're, talking about shoulder elbow, shoulder range of motion, scapulohumeral rhythm. What does your bench press form look like? How do you do with closed kinetic chain shoulder stability in like a high plank position? And then based off that, that's what we use to make your programming. So programming is rehab, but it's training. So rehab and strength training, especially for a lot of the people listening to this, you should know that those are the same thing. There's really not much difference between those two. It's just the intent behind the exercise and the entry point at which you are programming something for someone. So let's say this person with their shoulder pain, we may have 3 strength training days in there with a mix of strength and entry-level plyometrics. And then on their rest days, we have some active recovery days, which are some, more of your quote unquote physical therapy exercises, just to kind of keep things moving along and get in those movement snacks. And then as you progress, we change up programming. We program in block styles like anyone would for, typical strength and conditioning. And then, that's kind of just how we roll.
Okay, so you get the evaluation, and then how often are they checking in with you? How often do they get you on a call? And then how often does their program get updated?
Actually, they get unlimited chat access to your main PT and coach. And you also get weekly calls via Google Meet, so like video calls, kind of like Zoom. And I think those two pieces, along with merging rehab and strength training together, is why I have seen so much more success with remote rehab coaching than I ever did in the clinic. One, because these people are bought into their own health, their own fitness, their own rehab. And 2, you get so much more support. Like we are checking in after workouts. We have a weekly written check-in for you to complete. We're getting on calls. We're sending you messages. You're sending us videos of you doing certain exercises that we ask of you, or ones that feel weird or don't feel right. So there are so many more touch points throughout this process that I feel like you just don't typically get in a typical outpatient clinic, because clinicians are seeing so many patients in a day, not by their own fault. It's just like how some clinics are. Yep. And or you're not getting access to your clinician in between sessions.
Yep. Okay, so that makes a lot of sense. How much does that cost?
So rehab coaching costs $4.99 per month, where you get basically everything that I talked about. And then we do have the option to drop down to our fitness coaching tier at $375 per month. And that just means that if you've been working with us for like 5 months, your shoulder's feeling like $1,000,000, moving like butter, you're slinging balls at your adult softball league, and you're bench pressing like no one's business, but you still want to build some resilience, like you quite don't feel ready to go on your own, but you're not really limited by pain anymore, then we swap you over to the fitness coaching tier and we continue to work on and build up more of that resilience so that you don't have to worry about some of the previous sort of pain things coming back.
Okay. And so for $375 a month, what's the difference? Like, are you getting less contact points? Tell me what the difference is.
So the main difference is we're focusing more on performance than we are rehab. And then you're getting 2 calls per month versus 4.
Okay. And so what is a typical day look like in the Susie Squats? Like if I'm working for Susie Squats, what does my day look like?
So that's kind of the fun part, because I give my clinicians and team members a lot of say around their own schedules. So they basically make their own schedule. Obviously, I want them to have call availability for clients to schedule, for a good chunk of time throughout the week. But then I also require them to take 2 days off each week from calls where they do no calls, because work-life balance, I want you to take care of yourself. So your day may look like, if you're not a morning person, because I'm not a morning person, waking up at 8:30 or 9, playing with your dogs a little bit, making your coffee. Then you might have a client call at 10, 10:45, 11:15, and then you'll have lunch. And then you may have blocked off on your schedule some time to update some client programming in the afternoon. And then maybe you like working out in the afternoon better than the evening, and you go do your workout. And then you may have another client call after that. And then you can spend the evening with your wife, fiance, dogs, whatever, just kind of hanging out.
Okay, that's awesome. And then what is their comp structure, loosely speaking?
So their comp structure is based off of a percentage of the client. So if they have like 40 clients at the $499 structure, then they make a pretty good percentage off of each of those clients that they're coaching and that they're seeing.
Okay, and if they bring someone into Susie Squats, is it a different comp structure, different percentage?
So I haven't had that happen yet, but yes, it would be, and it is. They would get a higher comp structure if they brought in a client versus a client coming from me.
Okay. What other systems did you consider besides Train Heroic?
Oh my gosh, I looked at so many. I basically looked at all of them. I looked at Everfit. I looked at True Coach. I know, what's the other one? Trainerize, Train Heroic, obviously. And then I think I tried to look at a couple more. I know some have come out more since then, but basically what I was looking for was a app that was more focused on like strength and conditioning than rehab.
Yep.
And one that also was very like user friendly and a little bit gamified, which Train Heroic is. Like it's like just fun to use. And then also one that allowed for like group training for my group strength training program. And then each of Bailey, Pat's, and Emily's clients are on a team essentially. So if Pat's going out of town to go hiking in Yosemite, he can be like, hey team, I'm going to be hiking for the next 3 days. I'm going to get back to your message as soon as I can, but service may be spotty. Yep. So I really, wanted a bunch of different elements to that, and Train Heroic just happened to be the one that seemed to fit that the best.
Yeah, and they still require you to put everything in YouTube and then link from YouTube. Mm-hmm. Is that the way it works? Okay. Yeah. Is that cumbersome to you?
I actually like it because what I've done is my YouTube which is also Dr. Susie Squats. Every single form video that I have made lives on my YouTube for any clinician or coach to use. And so it's basically like a free exercise library for other coaches to use. So if you're listening and you're like, hey, I want a nice exercise library, go check out my YouTube. Okay. And with that being said, I am a very detail-oriented person. So my form videos just aren't like quick 10-second what an exercise looks like. I'm shooting different angles. There's a voiceover, there's a description, there's like top pro tips. So it's more to me than just, oh, here's a quick video on how to do it. It's like, here's what to do, here's cues. And if this is too difficult for you, then here's other exercises that you can possibly try.
Yeah. And on the user end, so I subscribe to a workout plan from DeFranco through Train Heroic. It's super easy. I love the YouTube clips, right? Because he does a great job of explaining inside of the clip. He also does great options within it. Here's how to progress it. Here's how to scale it, etc. So I love all of those things, and it tracks your progress. So I can see what I did last workout compared to today. So I think it has a lot of user friendliness. I love that. Okay, thank you for sharing that kind of entire journey and opening, like peeling back the curtain a little bit. Let's close up with our lightning round. You ready?
Yeah.
Okay, here we go. Number 1, braces versus Invisalign. Why choose one or the other?
This is going to be kind of a funny question because this goes back to hypermobility, actually.
Okay,
I had severe TMJ related issues because my palate was super narrow and my mouth was super small, which is something that's very, very commonly found in people with EDS. And so, yeah, like my teeth weren't even crooked when I started this journey and seeing a specialist in Dallas for this. And now I'm 4 years into treatment. I haven't had pain in 3 years. I'm at the tail end of the braces. And so Invisalign just wasn't an option for me because we needed to expand palate out to the sides and forward. And to do that, you need a lot more hardware than just the clear retainers.
Okay, so you're almost done.
Yes, almost done.
Amazing. Okay, I'm an Invisalign guy, having been a braces guy, so I figured there was something there. Okay, what's one thing you wish you could go back and tell yourself when you first started Susie Squats?
Oh gosh, that's so hard. Probably to believe in myself a little bit more and bet on myself more, just because the process of, posting on social media for fun in PT school was great, but I never really thought it would turn into what it has. And I'm so grateful for that. But, as I told you earlier, I had to be like shoved off of a cliff by my husband in order to start my actual company, which is Move Your Bones. And I wish I would have just believed in myself a little bit more, tried to push imposter syndrome to the side, and really just sort of just bet on myself and just trust the process.
Love it. That's great advice. What is one influencer in our space that everyone needs to be following?
Ooh, well, besides me,
definitely.
oh gosh, you're gonna make me choose between all my friends.
Yes. And there is a right answer to this, but go ahead.
Just one?
Yes, just one.
We're gonna go with Dr. Megzi DPT.
Also a true sports vet, Dr. Megzi. I had her on here. She was a freaking stud. So I second that. That was the right answer.
Yes.
She's outstanding. She's great with her progressions. She is outstanding interpersonally. So I second that. The most impactful book you've read in the last 5 years?
I don't read books.
The most impactful podcast you've listened to in the last 5 years?
Ooh, that's hard. I would probably say, and then not like a specific episode, but especially like for the audience that's listening, probably the Coach 'em Up podcast with Tim Riley and Zach Zillner, just because they do a very, very good job at having a wide variety of guests on their podcast that almost like challenge or contradict each other's beliefs a little bit. Because I feel like as clinicians, especially more like fitness forward, evidence-based, sports focused, we can kind of put our blinders on a little bit and only, do the things that we think are going to work the best. And listening to podcasts and other clinicians, other coaches that challenge our beliefs and our biases can be really, really good for just our overall growth.
Love that. Great answer. Okay, tell everyone listening, the thousands of sports PTs, how they can find you.
So you can find me at dr.susie.squats on Instagram, TikTok, YouTube, and my website is www.moveyourbonespt.com. And that actually came from going on lunch break walks during COVID when I was working at the clinic, and I'd always say, don't forget to move your bones today. So just like full circle, all in all right there.
Love that. And I love your MTV logo. It's a great call out. It kind of dates you a little bit because I think a lot of people probably look at it like, what the hell is that? But I loved it. So that dates me. Susie Squats, Susie Spirlock, you've been a goddamn pleasure. So thank you. Yeah, thanks for sharing your knowledge. To everyone listening, thanks for teaching me about hypermobility. Where were you when I was dealing with that kid who was dislocating her elbow? I had no idea what the F I was doing. So thank you for your knowledge. Thank you for your time.
Absolutely.
You've been awesome. Yeah, guys, thank you so much for listening. Let us know what you loved. Let us know what you hated. Check out Susie Squats on Instagram and everywhere else. I can't wait to continue to learn from you. Bye-bye. Bye-bye.